All right, I think we'll get started here. Appreciate everyone joining in on Zoom and those of you that are in person. So today I'm going to be talking about optimizing outcomes after geriatric hip fractures, which is a topic that really kind of bubbled up after we started developing a hip fracture pathway with Kai Hayes, who's going to join us, who's here in person if you can't see her. And for those who don't know her, is a nursing coordinator extraordinaire. She hangs out on the 2 East Ortho floor and has been really instrumental in getting the hip fracture pathway, along with many other protocols going. So the way we'll kind of organize this is I'll start just giving a general overview of the AAOS clinical practice guidelines for geriatric hip fractures. I'll then kind of subgroup those into pre, peri, and postoperative factors that impact the management of these patients. And then we'll discuss at the end kind of the implementation, preliminary results, and future directions of the hip fracture pathway. I'll introduce that, and then I'll let Kai give her presentation at the end. So in ways of a brief outline, I kind of mentioned this. There's a bunch of factors that impact the outcomes of these patients, and I broke them down into these three broad categories. And then at the end, we'll talk about the pathway. So as we all know, hip fractures are a growing problem. No matter who you are, if you're an orthopedic surgeon, or if you're a nurse or a physical therapist or emergency department physician and anesthesiologist, you need to be aware of this problem. It's estimated that there was 1.26 million hip fractures in 1990, and by 2050, that will increase by about 3 times as much. That will be about 4.5 million. It carries in significant morbidity and mortality, decreased quality of life, increased rates of depression, decreased mobility, increased rates of subsequent fracture, and need for care and supervision. You see on the diagram on the right some of the numbers associated with that. A third of patients end up dependent in a nursing home in the year after a hip fracture. 50% of people with one osteoporotic fracture have another one. 40% are unable to walk independently, and 60% require assistance at 1 year after injury. And then mortality is also very high after these fractures. So about a quarter of the patients will die after within a year of their hip fracture, and that can be even higher in the high-risk patients. In terms of scope for this, it's really just low-energy elderly hip fracture patients. We'll talk a little bit about the differences in morphology, femoral neck, intertroch, but that's the scope of this project or this presentation. So the first thing I'll bring up is the AAOS clinical practice guidelines for the management of hip fractures in older adults. These were the updated guidelines that were published in 2021. It was updated from the first edition that was published in 2014. And this is important for a number of reasons. One is that it's endorsed by a lot of the major orthopedic, ACUS, OTA, as well as physical therapy and PM&R organizations. The Joint Commission loves these guidelines, as I'm sure Kai will talk about. And also they do a really good job of organizing all of the vast information that's available about hip fractures and outcomes into one consistent grouping. To learn about the guidelines, you kind of have to know how they were put together. It's basically a giant systematic review. They organize a bunch of different PICO questions to answer certain outcomes, initiatives for hip fractures. They look through all of the research. There's a panel of experts that grades the research based on the quality of evidence and then gives recommendations based on that research. They use a grade methodology, and the inclusion criteria really for this particular clinical practice guideline was they needed to have at least greater than 30 patients per comparison group, and the average age of the hip fracture patient had to be over 65. So 8,678 abstracts were reviewed. They ended up with 213 articles that were deemed worthy of inclusion for review in the clinical practice guidelines. This table shows the level of evidence descriptions that are used. The statement strength varies from strong, moderate, limited, and consensus, and correlates with the evidence quality. And on a visual scale, they rate the evidence from 4 stars to 1. They basically give a summary of recommendations and options, and I'll go through those in a minute, but a strength of a recommendation is also either strong, moderate, limited, or consensus. And the impact of future research correlates kind of inversely with that. So a strong level of recommendation means that future research is unlikely to change that recommendation, whereas you go to something that's more of a consensus or a limited strength of recommendation, there's hope that there's more research down the pipeline that will strengthen those recommendations. So here's the summary of their main recommendations. There's 16 of them. I'll go through them kind of quickly now and then kind of individually in a little bit. Preoperative traction should not be routinely used for hip fracture patients, which we do not generally do routinely here. Surgical timing we'll discuss. They recommend 24 to 48 hours. VTE prophylaxis should be used in all hip fracture patients. We'll talk about that as well. There are certainly anesthesia considerations. Either spinal or general anesthesia is appropriate for hip fracture patients. There's a lot of recommendations in terms of the stability and type of fracture. So the femoral neck recommendations are that arthroplasty is recommended over fixation for unstable femoral neck fractures. Unipolar and bipolar are options for your femoral neck hemiarthroplasty. Total hip versus hemi we'll talk about. We'll talk about cemented versus uncemented stems and then different approaches. In terms of intertroch fractures, these stable fractures can get a sliding hip screw or cephalomedullary nail. The unstable fractures, either your subtroch reverse obliquity, should be get a cephalomedullary nail. There's some data about transfusion limits, and we'll cover that as well. And multimodal analgesia, as well as TXA and interdisciplinary care we'll touch upon at the end. There's 3 summary of options that they talk about. These options are formed when there's little or no evidence, and there's 3 of them. This first one's interesting, is that patients with stable femoral neck fractures, either hemi, internal fixation, or sometimes even non-op care may be considered. In terms of short versus long cephalomedullary nails, that's a debatable topic based upon their review. And then in terms of weight-bearing post-op, we can discuss some of the results there. So we'll start talking about the preoperative considerations. We'll talk about multimodal pain control, time to OR, pre-op clearance, traction, and VTE prophylaxis. So the first topic is nerve block and pain management. This is a high level of evidence and a strong recommendation for using multimodal pain control as well as a preoperative nerve block. There's a lot of high-level studies that cover this topic, but what makes it a little hard to interpret is that there are various different blocks and regimens in terms of the pain medications. The fascia iliaca block is generally what we use here and is becoming more and more popular, but there's also other femoral nerve blocks and obturator nerve blocks as well. It's important to know the anatomy in terms of the innervation of the hip. On the picture on the left here, you have the nerves innervating the anterior portion of the hip, the femoral nerve, obturator nerve, and then posteriorly, you have your superior gluteal, nerve quadratus femoris, and inferior gluteal. The vast majority of blocks that are used in hip fracture patients do not anesthetize the posterior hip joint. And this, I included a diagram of the fascia iliaca block shown on the right there. There's something called the 2-pop method, where you can imagine that the needle goes through the fascia lata and then the fascia iliaca. And the block is done in a potential space that encompasses the femoral nerve, the lateral femoral cutaneous nerve, as well as the obturator nerve. And it seems to be increasing in use just because of its ease of reproducibility. This was a study in 2018. It was a randomized control study of a fascia iliaca block versus no block. There were 44 patients in each arm. The control group had no block and had a standardized pain regimen. As shown in this table, the block group had a shorter hospital stay by about 3.5 days compared to the regular opioid group. The top table here shows that the satisfaction with the pain regimen in the block group was significantly increased compared to the pain group. And that is also shown down on the tables below. The figure 2 on the bottom left shows VAS pain scores at rest. They're very similar throughout, other than on the morning day of surgery, which is that time T2 point. And then T1 and 2 on the bottom right shows the VAS pain scores at passive movement. That's 1 hour after analgesia, and T1 and T2 is the VAS scores on the morning of the surgery. This is another study analyzing the impact of regional nerve blocks on pain and functional outcomes. It was published in the Journal of American Geriatric Society in 2016. It was a randomized control trial across 3 New York medical centers. The study group received a single femoral nerve block and then a fascia iliaca block by anesthesia within 24 hours. The control group was again, a standardized pain regimen. Shown on the left is the VAS score after admission to the emergency department. As you'd imagine, the block patients had a significantly decreased pain score initially after the block compared to the control pain regimen. And then similarly to the last study, the pain with transfers and walking on postoperative day 3 was significantly better in patients with a nerve block than those without. So main takeaways, I think this is a really important part of treatment of hip fractures. Nerve blocks need to be considered for every patient. Several studies show that the emergency department can perform the blocks versus anesthesia. Here we generally have anesthesia perform the blocks just because they're more familiar with it. And that's just kind of how we've set up our pathway. But other institutions may have emergency department physicians that feel more comfortable providing these blocks. Orthopedic surgeons, while we treat these fractures surgically, we should be advocating for our patients that they should be getting a block and trying to implement standardized protocols that improves the amount of patients that are getting preoperative blocks. Multimodal, as with everything, multimodal pain management is important. In terms of the type of block, again, it's very provider dependent, it's trainer dependent, and there's no obvious advantage of one over the other in the literature. In the future, certainly other options, other blocks will pop up, and there's also some data on periarticular injections postoperatively. Time to OR for hip fractures is always a hot button topic. The clinical practice guidelines give it a low quality of evidence, but a moderate strength of recommendation in that patients that go to the OR within 24 to 48 hours have better outcomes. And while there are somewhat low level studies, there's so many of them that show a positive impact on mortality rate that the recommendation is a strong one. It can be confounded by patient comorbidities. There is some heterogeneity in terms of what different studies use as early versus delayed time to the OR. This is one study published in JAMA in 2017. It was a retrospective population cohort in Canada, 72 hospitals in one province over a 5-year span. There were 42,000 patients. The overall mortality rate at 30 days was 7%. They used a lot of statistical analysis to examine a threshold inflection point that they found at about 24 hours after that, the 30-day mortality started to increase. This is another table from that same study showing that the primary outcome of 30-day mortality as well as several secondary outcomes, including PE, pneumonia, MI, and total composite outcomes were significantly worse in the delayed group after 24 hours. This is another study kind of highlighting some of the variability in the data in terms of what is considered early versus delayed surgery. This was a 2018 study published in Scientific Reports. It was a systematic review and meta-analysis of 28 prospective observational studies with 31,000 total patients. As you see in this table, several of the studies showed a significant decrease in mortality rate for both cutoffs of 24 and 48 hours. This is another table showing the perioperative complications for different studies and different cutoffs. You can see one of the studies in the 24 hours was statistically significant, 2 of the 3 in the 48 hours, and 1 even in the 72 hours. So the data is a little all over the place in terms of what is considered early versus late. But the point remains that delayed surgery generally leads to increased mortality. There was a question, actually, a patient that I presented at Fracture Conference last week about the timing to surgery for total hip arthroplasty, which may be a little different, just given that generally you need a specialist to perform a total hip rather than a hemi, which most general orthopedists can do. So this was a study published in the Bone and Joint Journal in 2023. Actually, a couple months ago, was a retrospective cohort study using data from the Scottish hip fracture audit. There were 1,375 patients who underwent total hip for hip fracture. They used 36 hours as their cutoff between delayed and not delayed, showing no difference in 30 or 60-day survival. There was a trend towards improved mobility for the not delayed group, so the early group, as well as a lower length of stay, a shorter length of stay, as you might expect in the patients that were able to get to surgery before 36 hours. So main takeaways for surgical timing of these patients, as I mentioned, in general, increased delay is associated with increased mortality. A reasonable target is 24 to 48 hours. Decreasing the time to surgery is also associated with lower cost and utilization of healthcare resources. But importantly, there are many barriers to getting a patient, as we all know, to getting to the OR. Not only patient comorbidities and clearance, as I'm sure all the residents are well aware of, but it's also a medical center environment. A lot of these studies are big hip fracture registries or databases or studies that are done at big level 1 trauma centers that have a dedicated orthopedic trauma room and have a lot of resources. But oftentimes these hip fractures are being treated in community hospitals or places with less resources. So staffing or availability and surgeon availability can hinder the time to OR. So those are all things we need to keep in mind and try to work on as we move forward. Everyone's favorite topic in terms of pre-op clearance. It's not nearly as straightforward as I would have thought looking into this, but the ACC and AHA clinical practice guidelines came out in 24 and are very robust in terms of providing guidelines for who needs a cardiology consultation, who needs further workup with an echo, and who is low risk, intermediate risk, and high risk. And there's a lot of different calculators and things that people use. But I bring this up particularly because this data really is referenced in the literature very frequently. And knowing that it exists and advocating for its use and standardization among not only a place like here where we've developed a hip fracture pathway, but in smaller community hospitals where you can impact its use by anesthesiologists and medical teams and cardiologists, it's important to be aware that these exist. I thought this was an interesting study in 2020 out of the Netherlands. It was cardiac overscreening hip fracture patients. And what they did was they looked at those ACC and AHA clinical predictors, low risk, intermediate risk, and high risk. And you can see how the intermediate and high risk patients kind of progress in terms of their cardiovascular history. And what they did was did a chart review on all their patients prospectively and determined which patients had appropriate screening. So this table shows the low, intermediate, and high risk patients. And as you might imagine, the high risk patients ended up having a more of a delay to surgery than the low and intermediate risk patients, which makes sense if they needed more workup preoperatively. This data shows that 89% of the patients were quote unquote appropriately screened. 11%, however, were not appropriately screened. 8 patients in the low group, 9 in the intermediate group, as well as 2 in the high group were quote unquote inappropriately screened. This shows the complication rate. I think this is an important slide because really all of the statistical significance in terms of complications are either in the intermediate and high group. And what that says to me is that, you know, the guidelines in terms of preoperative clearance and who is high risk, who is intermediate risk, and who is low risk tend to work. So it's important that we follow those guidelines and that we can advocate for their use because they seem to be very effective, at least in this study. There's another couple graphs showing that the high risk group has higher in-hospital mortality, 30-day and 1-year and 2-year mortality. You can see the Kaplan-Meier curve for survival, where the high-risk group, as you might expect, has about a 70% mortality rate at 2 years. And that tracks at all time points. So in terms of pre-op clearance, we are not cardiologists, we're not medical doctors, we're not anesthesiologists, but we should be aware of what those people use to clear our patients and evaluate our patients preoperatively. Something that I think we've learned doing the hip fracture pathway here is incorporating anesthesia early on. Anesthesiologists are very good at evaluating patients and deciding who is high risk and who is intermediate risk and who needs cardiology clearance. And so I think involving anesthesia early on in not only the development of these pathways, but evaluating these patients early can help getting to the OR faster. I'll mention this briefly, just, for standard geriatric hip fractures, there's really no data to support the routine use of preoperative traction. Exceptions can certainly be made in certain subtroch or proximal femur shaft fractures, but for the vast majority of patients, there's no evidence to suggest that preoperative traction improves outcomes. VTE prophylaxis could be its own topic. We've talked about it many times, but one of the main points of hip fracture care is that patients need to be on some sort of prophylaxis. They're at super high risk for thromboembolic events. There's a strong evidence across the literature for routine prophylaxis. The problem is there's a lot of heterogeneity in terms of specific VTE agents, frequency, dosing, duration. But it's important to remember that everyone needs pharmacologic prophylaxis. We generally use subcutaneous heparin or Lovenox here. There's some studies in support of aspirin, but some others not so much. But there's also other forms of VTE prophylaxis. We need to get them out of bed early with our PT and nursing staff. All patients, unless they have a contraindication, should get some sort of mechanical prophylaxis. So these are very important. We'll move on to the perioperative considerations. We'll start with TXA and then we'll talk about a couple others. So TXA or tranexamic acid, there is actually high quality of evidence and strong recommendation in terms of the clinical practice guidelines for its routine use in hip fracture surgery. A lot of us are aware of its use in the joints literature as well as some others. It's been associated with lower blood loss and transfusion rates without a higher incidence of mortality or symptomatic thromboembolic events. I'll mention one or two studies here. This is a bone and joint article from 2016. It was a single center placebo-controlled double-blinded randomized control trial for extracapsular fractures undergoing short intramedullary nails. There were 72 total patients, 39 in the placebo group and 33 in the TXA group. As shown here, there was a significant decrease in total blood loss in these patients. So total blood loss in this paper was calculated based on the hemoglobin. So it was preoperative hemoglobin, and they use a formula that's used in a couple of different papers. It's not the most accurate thing. But it's usually measured on pre-op and then post-op day 3, and that's the difference there is how they measure it. This is another article out of the Journal of Orthopaedic Trauma in 2017 at a level 1 academic center. It was a prospective double-blinded randomized control trial. Patients undergoing total hip arthroplasty for femoral neck fractures within 72 hours of presentation. They used the same calculation of blood loss for this. So it showed on postoperative day 1, 2, and 3, there was more blood loss based on their calculations in the placebo group than the TXA group. For just reference, in this paper, they used 15 milligrams per kilogram, or max out at 1 gram before incision, and then a second at wound closure. Here was the Kaplan-Meier estimates for adverse events. So they did show a significant decrease in blood loss with TXA without any change in thromboembolic events, wound complications, reoperation, readmission, and death. So main takeaways, I'm not sure, I don't think it's something we use routinely here, but it's, I think, something that we should consider using moving forward. In terms of who needs it or who should get it, there's different advocates. For some people think all hip fracture patients should get it. Some people, or some studies, advocate for just patients with certain risk factors or a lower preoperative hemoglobin. It is to note that it's still off-label use even in the joints literature. Even for joints applications. Dosing is highly variable across all different studies, but most commonly it's about 1 gram prior to incision and a second dose 3 hours later. Exclusion criteria is also a little all over the map. Absolute exclusion would be an allergy to TXA. There's some renal, you need to be careful in renal patients, active malignancy, and usually anesthesiologists are very familiar with TXA and will discuss with you any potential contraindications. So future directions in terms of research, as well as using this potentially in our practices, dosing, method of delivery, and then more high-level studies really to look at the effects of TXA in this cohort. In terms of transfusions, I'll just mention really quickly, they recommend a threshold no higher than 8 grams per deciliter in asymptomatic post-op patients. There was no significant difference between liberal versus restrictive transfusion limits in several studies. This one in 2011 was published in the New England Journal of Medicine. It was called the FOCUS group. The theory was that in patients with higher cardiovascular risk, if you used a liberal transfusion criteria of 10 grams per deciliter, you might improve outcomes, and that was shown to not be the case. Both groups, there was no significant difference in terms of death, mobility, where they went after, or functional scores. So really, this is what we do here. I'm not sure that it's standardized in writing. I think Kyle will talk about that, but we use generally a threshold of 7, and then for cardiac patients, 8. Anesthesia, there's really no clear benefit in several high-quality studies in terms of spinal versus general anesthesia. Both are very well tolerated. This was a 2021 randomized trial published in the New England Journal of Medicine. There were 1,600 patients enrolled in a 1-to-1 manner. Primary outcome was death or inability to walk 10 feet at 60 days. There was no significant difference in terms of any of the primary or secondary outcomes, including mortality rates and mobility outcomes. So in terms of what we decide, again, it's a shared decision-making. Anesthesia really drives the ship here, but it's good to know that there's really, for the vast majority of patients, both are fine options. The next several kind of topics I'll talk about perioperatively are really kind of basic principles that most of us are very familiar with, so I won't spend too much time on them, but they do make some recommendations that I figure I might as well go over. The first one, I'll kind of break them down into femoral neck fractures. In stable femoral neck fractures, hemiarthroplasty, internal fixation, or non-operative care may be considered. This was a very weak recommendation that they made. I think it's very patient and surgeon dependent. When you have a non-displaced or impacted femoral neck fracture, we tend to use a lot of cannulated screws here. But there are some studies that show hemiarthroplasty may have improved short-term outcomes. There's one study that shows reasonable data for non-operative management in a certain selection of patients, but really our only indications still remain non-ambulators, those who have minimal pain or are really high risk for surgery. This was one article in JBJS in 2019 that compared screw fixation with hemi. It was a multi-center randomized control trial in Norway, 111 patients in the can screws group and 108 in the hemi group. Primary outcome was the Harris hip score. There was no significant difference between the two. There was some difference in mobility in terms of a get up and go tests in favor of a hemiarthroplasty at 12 and 24 months, as well as subjective quality of life scores. In terms of reoperations, there is a slightly higher reoperation rate for the screw fixation group. 20% in that group compared to 5% in the hemiarthroplasty, with 12 of the 22 reoperation rates for screw removal and total hip arthroplasty. In terms of total surgical complications, there is a slightly higher rate of cannulated screw fixation compared to hemiarthroplasty. Again, most of those being fixation failure or non-union. So the take home really is both are options. There's a subset of patients that may have short-term improvements in a hemiarthroplasty, but that cohort is not really well defined in the literature at this point. There's been a lot of talk lately about whether to cement or not cement. The clinical practice guidelines are very much in favor of cementing femoral stems for those patients undergoing arthroplasty for femoral neck fractures. There are high-level studies that support cement use for improved short-term patient-reported outcomes, and they cite a lower periprosthetic fracture risk. However, it is not without its drawbacks in that it has higher surgical time and blood loss in the cement group. This is one of the studies in 2023 in Bone and Joint Journal. It was a 3-year follow-up of 400 patients randomized to cemented and cementless hemi for femoral neck fractures. I highlight this study because it's recent and has kind of decent midterm follow-up. There were 210 patients, and only one was lost to follow-up at that 3-year mark. The overall mortality rate was 52.5%. As you can see on this graph on the left, the uncemented group is on top and cemented group is on bottom. For the first year, there was a reduction in mobility or better mobility in the cemented group compared to the uncemented group. There was no difference in pain scores across any of the time points. And this was one of the few studies that did show a slight mortality difference going out to about 3 years in favor of cement versus cementless. So really, the main takeaways when I looked at all this is I think there's cemented stems are a good option in this patient population. There has been an increased use of them lately over the last decade or so. There are trends that show lower periprosthetic risks and better short-term outcomes. But that does come at an increased risk of blood loss as well as an increase in surgical time. The benefit of overall mortality and medical complications is still unclear, though, despite the results from that last study. And I do think that, we do press fit a lot of hemis here, and I think that's okay for a lot of people. While there is some statistical significance in the data, that overall difference may not be super significant. So it is a lot of surgeon dependence, but if you don't do a lot of these, I think it's safer to do cement. In terms of surgical approach, there's a lot of different studies that are all very heterogeneous. There's really been no surgical approach that has been consistently shown to be any better than any other. So it really is kind of surgeon preference and should be based on their comfort level with that procedure. In terms of arthroplasty versus fixation for unstable or displaced femoral neck fractures, we all know that arthroplasty is the treatment of choice in the elderly population for displaced femoral neck fractures. There's 6 high-quality studies that they reference, all with consistent results favoring arthroplasty with better functional scores, pain scores, lower reoperation, and complication rates. However, there is a composite analysis that doesn't show any significant difference in mortality rate. In terms of total versus hemi, they actually downgraded their strength of recommendation compared to the 2014. There is high quality evidence, 4 high quality and 10 moderate quality studies with consistent results. In terms of the total hip, most of them show some small statistically significant functional benefit in total hip patients versus hemi. But the hemi group has a small decrease in dislocation and instability as well. Mortality is generally similar. There is some heterogeneity in these studies in terms of patient confounding factors, and it really kind of, again, relies on the surgeon as well as the patient to really go over both options and come up with something that you're comfortable with. The function of the patient needs to come into consideration, as well as what I talked about earlier in terms of surgeon familiarity and the availability of the surgeon to do the total hip. In terms of unipolar or bipolar, there's really no difference in terms of the studies that they recommend. There's 10 moderate and one low quality study that all showed relatively consistent results. There was no significant difference with most outcome measures, as well as mortality. There was some isolated studies that showed a statistically significant difference favoring the bipolar group, but they do mention some lower cost of unipolar heads. So I think both are options. In terms of the treatment of intertroch, again, kind of basic principles apply, but I'll go over them quickly. In stable intertroch fractures, as shown here, use of either a sliding hip screw or cephalomedullary device is recommended. The studies that they reference show similar functional outcomes, hospital stay, similar rates of collapse and mortality. But some studies individually show differences, including potential for reduced hospital stay, improved walking ability, and fewer implant-related complications for cephalomedullary nails, while a sliding hip screw costs less. In terms of unstable fractures, they should really be treated at this point with a cephalomedullary device. 2 high and 9 moderate quality studies showed significant better outcomes with a cephalomedullary device versus sliding hip screw. The problem with a lot of these studies is there's so many different implants. There's a lot of different fracture morphologies that are hard to standardize, and there really hasn't been shown to be any mortality difference. Similarly, with reverse obliquity or subtroch fractures, there's heterogeneous implant design, but it does favor cephalomedullary nail versus sliding hip screw. In terms of short versus long cephalomedullary nail, they really give a limited opinion on this. They quote 1 moderate and several low quality studies. In terms of the short cephalomedullary nail, most of the studies report a lower surgical time, blood loss, transfusion rate, fluoroscopy, and cost compared to long. There's really no difference in adverse events or patient-reported outcomes, and there's no significant difference in periprosthetic fracture, except in one low-level study. So I think that's important to be aware of. We tend to do a lot of short hip nails here, and I think that is a very reasonable way to go. There are several studies that look at the distance of subtroch extension, and if you're in that 3 to 4 range, then you really should consider a long nail. I highlighted this 2018 study from the Journal of Orthopaedic Trauma. It was a randomized prospective study, 168 patients, 80 short nails, 88 long nails, and a mean follow-up of 13.9 months. Primary outcome measure was the SF36 and the Harris hip score. The table on the left here shows that operative time and estimated blood loss were statistically significantly less in the short nail versus long nail group. The complications were, there was no difference. And then in terms of functional outcomes, the SF36 were similar, but there was a better Harris hip score for the short nail than the long nail. In terms of post-op considerations, I'll be relatively brief here because I think Kai will touch on some of these as well. Length of stay is a very important part of caring for these patients. Getting them out of the hospital is important, not only from a outcome perspective, but just a resource perspective. It's multivariable. Time to OR is a big factor. Early mobilization is a big factor. Pain management, as well as social work and all your other teams working together to get these patients out the door. Weight bearing, weight bear has tolerated almost every hip fracture that we treat here. There's not a ton of high level evidence to support that, but there are some low level studies, and it's really an emphasis on improved function and getting patients out of bed. There was a study in 2018 in the Bone and Joint Journal looking at 49,000 patients in the National Surgical Quality Improvement, or the NSQIP, hip fracture data set. And they looked at the effects of restricted weight bearing on the adverse events. And they did show that after controlling for patient and procedural factors, the odds of any adverse event, delirium, infection, transfusion, length of stay greater than 6 days, and 30-day mortality were all higher in patients with weight-bearing restrictions. There was no difference in thromboembolic events or return to OR or readmission. So really the takeaway is almost all these patients should be weight-bearing as tolerated. Early mobilization improves outcomes. They did mention in that 2018 study that about 25% of orthopedic surgeons do routinely restrict weight bearing. I thought that was interesting, and I'd be curious to see if that's trending towards less. But they're mostly just kind of retrospective low-level studies. Interdisciplinary care has been really big in the world of hip fracture protocols and care. There are many high-level studies showing that they improve overall outcomes, and it includes co-management with geriatrics in terms of preventing delirium, doing med management, as well as interdisciplinary care with nursing, dietary, PT/OT, management of osteoporosis, discharging patients on VTE prophylaxis. And it has been shown in many studies to decrease mortality, improve functional outcomes, reduce falls and quality of life, return patients to the community, as well as ensure patients are on appropriate management for osteoporosis and nutrition. So I'll introduce this briefly. If you've never seen this before, this is kind of our hip fracture pathway that we've developed. I won't go through every little box, but the general trend is a patient comes to the emergency department, they get an X-ray, it shows a hip fracture. The orthopedic resident is contacted and activates the pathway. The hip fracture page then goes out to all the stakeholders, anesthesia, the residents, the orthopedic coordinator, the medical team, bed management, the ortho APNs, and the OR desk. And the anesthesiologist then goes evaluates the patient. If the patient is quote unquote clear for surgery, after their evaluation, then they go to the preoperative area, they get a block and they go to the OR. If they're not cleared or they need further workup or there's no OR availability or something, then they'll be admitted to the medical team and we'll go to the OR after clearance when there's availability. We are doing a research project on this. These are some very preliminary results of that project. It was based on a chart review from Epic of all the patients that have been treated, that have had hip fractures treated surgically at Robert Wood Johnson University Hospital since Epic was implemented. And we've been grouping them into pathway and non-pathway patients. We have not done any statistical analysis yet, but as you can see, the length of stay and the time to OR is much less for the pathway group, as well as the instance of pre-op echoes. So we're looking forward to kind of seeing what we can get from that data and go from there. In terms of challenges and next steps, Kai will talk about that, but from my perspective, anytime you're working with different groups of people, it's hard to get multidisciplinary buy-in. You really have to unite the group towards a common goal, and I think people have their own motivations. So it's been, I think, a good challenge, but a rewarding one for Kai and the team to move through things. In terms of when we use it, it's really only active at this point during the day and during the week. And so that's limited our ability to really activate the pathway outside of those hours, either after hours or on the weekend. So expanding that is certainly something we'd like to do. Spreading awareness that it exists, giving talks like this, I think are important. And then implementing them at other hospitals. That's going to be a challenge, but I think is something that's worthwhile. The residents cover not only here, but we're at St. Peter's, we're at Somerset, and doing hip fractures, they come in all the time, can be a real pain. And so I think using some of these principles, whether it's a formal hip fracture pathway or something, is worth looking into. And in general summary, I think the AOS clinical practice guidelines are a good framework. While as orthopedic surgeons, our main role is certainly to fix the hip fracture, we do need to be aware of the other factors that influence the outcomes of these patients, and look forward to working on the hip fracture pathway more. These are references. If anyone has questions now, I can take them briefly, or we can do that at the end after Kai's given her talk. I'd like to thank Kai, Drs. Gatz, Avian, and Pushlin, and Todd, who's been instrumental in the hip fracture pathway. With that, I'll introduce Kai.
Hey, Jeremy, Swan
Yeah,
here.
go for
Hey,
it.
thanks. Just because I might have to jump off
Sure.
before Kai finishes. Um, just outstanding summary and overview of a lot of data, very important stuff. Um, just to give a sort of insight into community hospitals, these things that you talk about that many of us take it for, as common knowledge, they take a long time to be adopted at these community hospitals, meaning like almost a generation in terms of switching from uh bipolar to unipolar, or from long
Yeah.
nail to short nail, or whatever it is. And I think it's very important that you're discussing it, and it could be worthwhile presenting something like this at the NJOS meeting.
Okay.
So
Yeah.
just FYI, and thanks for the summary.
Yeah. Good to know. I appreciate it. Yeah.
Jeremy, I thought that was just a great talk. I mean, it was so applicable to what we're doing, and hopefully you can send me a copy of this, and some of the community hospitals I go to down here, we can start to look at some of these things, because I doubt many of these are being implemented. But as you went through this, what's the low hanging fruit? What are you going to take away from this? And if you can change one thing at Robert Wood University Hospital, what is it going to be that you think you can accomplish here in maybe the next 18 months before you leave?
Yeah, I mean, I think we do a lot of really good things here. I think, for me, looking at the TXA data is really interesting. We don't routinely use TXA in hip fracture patients really, as far as I know, very frequently at all. We do have a relatively high rate of transfusions though. So if we can implement a standardized protocol for TXA, I think that is a reasonably low hanging fruit that could have some positive impacts. And I know, Kai's working on a lot of stuff too that she'll talk about.
Jeremy, you mentioned that the TXA is an off-label use for hip fractures. How much does it cost, and where does the cost get passed through to?
That's a good question, and I don't have a good answer for you. I can look it up, but Dr. Gat's saying it's cheap and it's pretty widely used now. So
you brought up transfusion recommendations in the setting of hip fractures. Is there any data or evidence for stratification based on an intracapsular versus extracapsular fracture pattern, displaced versus non-displaced? Because I know it changes our treatment options.
yeah, in terms of transfusion threshold, I did not see any. The different studies use extracapsular or femoral neck fractures. It just kind of depends on their cohort, but I'm not aware of anything directly stratifying, extracapsular versus intracapsular in terms of a threshold for transfusion. Good question.
Just to answer, it's about $4 or $5 for a gram of TXA.
Omar just bought a bunch, so he's ready to rock. Yeah. All right. We'll let Kai do her